is that, so we actually have 3 dimensions in the clinic, right? One of us is horizontal, one is vertical, one is sagittal. In fact, what Dr. Sue said just now is right. In our clinic, in fact, what patients are most concerned about must be the sagittal orientation, right? It's very easy for us physicians to just focus on sagittal orientation. For example, how to adjust the coverage just now. But in fact, this patient is not a coverage problem. He's a vertical problem. So what we see most often in the clinic is probably a sagittal problem. But you know what? In fact, a mouth and system, we're actually reconstructing. And when we rebuilt the piece, you have to consider measurements, right? When you make a full mouth, 1 foot, the one thing you have to consider is the width. It's vertical and it's sagittal. It's all 3 dimensions when considering this 3 dimensions. The hardest part is the landscape. It's not easy horizontally. If you have a lot of lateral difference, is it because we don't have bones? I have repeatedly emphasized to you, the landscape is actually boneless. So if you want to do a lot of bow extensions, I want to do a lot of bow shrinkage. In fact, your skeletal condition does not allow. So when you see a patient with full dentition, you have to understand that this patient is difficult. Well, when you see a patient with unilateral positive locking, you have to understand that this patient is difficult to adjust, because when you turn landscape, the other vertical and sagittal lines change. Can you understand? So actually the most difficult adjustment in the clinic is the lateral, but there are not so many horizontal problems. You could have 10 patients. Horizontal problems maybe about 20%, 30%, but it's not all. Everyone can, after understanding the horizontal issue, the most difficult adjustment is the vertical direction. The vertical direction is very difficult to adjust. The vertical problem, if nothing else. It should be a problem that every orthodontic patient will encounter. Can you see what I'm saying? Because you need to know. In fact, the vertical problem, although it is very easy to become your main theme, it's because you didn't take it seriously early on. Early on, we all put our focus on the sagittal upward. But think about this. If your vertical orientation is not well adjusted, your sagittal orientation can't be good. So in the clinic, in fact, in terms of probability, every patient should have a vertical consideration for you. If you don't consider the vertical direction, this patient won't do well. It may not be over yet, right? So I think the vertical aspect is very, very important. And then it's sagittal. If you adjust the horizontal and vertical directions, the sagittal problem becomes simple. So in order, you have to look at the landscape first. Now look at the vertical, look sagittal again. When you adjust the horizontal and vertical directions, the sagittal orientation is naturally easier to adjust. Don't do it the other way around. If you keep thinking, wow, how do I get my teeth back? The coverage has got to be reduced. You're going sagittal. If you go vertically, you have a problem. You get that. So let's say, as a thought, we need to think of it in these 3 dimensions. But why don't we take out the horizontal side separately? It is because it is possible that the proportion of lateral in your clinical practice is small. Look at you. You take 10 patients. Maybe only 1 or 2 have lateral problems. Most of the horizontal problems are not so many. Of course, children are different. Children may have to expand the palate. Let's start with a normal pinch for the combined model, because it is easy for children to expand the palate.